Welcome to the Academic Express. I am absolutely thrilled to have you on board today. We're going to explore something that is frankly the very foundation of medicine and human biology. Think about it for a second. Before a medical detective can solve a complex case, they need a map. Anatomy isn't just some boring list of confusing Latin names you have to memorize. No, it's a powerful, dynamic, geographical tool. It's literally the definitive map of the human body, allowing clinicians to navigate incredibly complex biological terrain with absolute pinpoint precision.
So, ask yourself this. You go to the doctor and say, "Hey, my stomach hurts." How do they actually pinpoint exactly where the problem is? How do they translate a vague symptom like that into exact, actionable anatomical coordinates? Well, it takes a universal language, a very specific set of rules, and some seriously incredible technology. To really answer that, let's zoom out and look at the big picture. Imagine the human body as this magnificent three-dimensional geographical map just waiting to be explored. Just like a map of the world has an equator, hemispheres, longitude, and latitude, the human body has its own internal grid lines, distinct regions, and a universal clinical compass. Whether a clinician is just doing a standard physical exam on the surface or using an MRI to look deep inside, they rely on this exact same cartography to ensure they never, ever get lost.
Okay, let's dive into this. Here is our roadmap for today's explainer. First, mapping the human body. Second, the anatomical position. Third, navigating directional terms. Fourth, slicing up anatomical planes. And finally, looking inside with medical imaging. All right, Section 1, Mapping the Human Body. Let's talk regional terminology.
Before we can even think about giving specific directions, we have to divide the body into territories. Basically, the human map is split into two main divisions. You have the axial skeleton and the appendicular skeleton. Think of the axial skeleton as the central core. It's like the trunk of a tree. This includes the cephalic region, which is the head, the cervical or neck region, the thoracic chest region, and the abdominal region right where your umbilical area sits. Now, attached to this core is the appendicular skeleton. These are your appendages, your upper and lower limbs reaching from the acromial region of the very tip of your shoulder all the way down to the pedal region, which is your foot.
Moving right along to Section 2, the anatomical position, or establishing the baseline.
To use any map properly, you have to have a universal starting point, a baseline. What's incredibly interesting here is just how rigid the rules for this baseline are. The anatomical position isn't just casually standing up. Not at all. The person has to be standing upright with their feet together and toes pointing straight forward. The mouth is closed, the facial expression is totally neutral, and the eyes are open and focused on something in the distance. Furthermore, the lower margin of the eye orbit has to be perfectly level with the top of the ear opening. It's a highly rigorous standard.
But here is the absolutely crucial rule. It's all about the placement of the hands. The arms must be right by the sides with the palms facing forward and the thumbs pointing outward, exactly 90 degrees away from the fingers. Now, I have to warn you, this specific hand placement is a classic trick question on anatomy exams. Why? Because when your palms face forward, it physically changes the relationship of the bones in your forearm. This specific posture is literally the baseline for every single piece of directional terminology we're about to discuss.
Which brings us to Section 3, Navigating Directional Terms. It's time to bring out the clinical compass.
Once our patient is locked into that anatomical position, we can start navigating. First, let's look at the vertical plane. We use the terms superior, meaning towards the head, and inferior, meaning towards the feet. It's super vital to remember that these terms strictly apply to the axial skeleton, that central trunk we just talked about. For example, your frontal region or your forehead is superior to your nasal region. Conversely, your mental region, which is the chin, is inferior to your oral region. Makes sense? Next up, we measure against the absolute center of the body. If we were to draw a line right down the middle, structures moving towards that midline are called medial, and structures moving away from it are lateral. Remember that crucial rule about the hands we just went over? Because the palms face forward and the thumbs point out in the anatomical position, the thumb, which is clinically called the pollex, is positioned physically away from the body center. Therefore, the pollex is lateral to the little finger. Now, what about the limbs? Well, we actually don't use superior and inferior for the arms and legs. Instead, exclusively for the appendicular skeleton, we use proximal and distal. Proximal simply means closer to the point where the limb attaches to the body, while distal means further down the limb. So your hand is distal to your elbow. But your shoulder, the acromial region,
is proximal to your upper arm, the brachial region.
Let's see how this compass actually adapts to modern clinical practice. The map of the human body is constantly evolving, and so the way we talk about it has to evolve too. Medical texts are emphasizing that anatomy has classically been taught using a very strict sex-binary model of female and male. However, clinicians today increasingly recognize biological variation. This includes intersex individuals, as well as transgender and non-binary individuals who might be receiving gender-affirming care that physically alters their anatomy.
So, to provide accurate and sensitive care, modern best practices dictate that clinicians shouldn't just make assumptions based on a patient's gender presentation. Instead, providers take what's called a respectful organ inventory, based purely on the anatomy that is actually present. By using inclusive, non-binary anatomical terminology, like saying upper body instead of breast, or referring to gonads instead of ovaries or testes, it ensures the patient feels respected, all while allowing the clinician to diagnose, screen, and treat just as effectively.
All right, Section 4, Slicing Up Anatomical Planes, the internal grid lines.
So far, we've only really navigated the surface, but to look deeper, clinicians use three-dimensional conceptual cuts. These are known as planes, and they reveal the internal grid lines of the body. There are three major ones you definitely need to know. The coronal plane is oriented vertically and slices the body into anterior or front parts and posterior or back parts. The sagittal plane also runs vertically, but it cuts at a right angle to the coronal, dividing the body into left and right halves. And finally, the transverse or axial plane cuts horizontally, dividing the body into superior top portions and inferior bottom portions. These planes, they are the absolute foundation of modern radiology.
And that leads us perfectly into Section 5, looking inside with medical imaging, the satellites of the human body.
If directional terms are our compass, medical imaging devices are the satellites of the human body. They use these planes and coordinates to peer right through the skin. Think about a CT scan or computed tomography. A CT scanner rotates an X-ray tube all the way around the patient, capturing a multitude of those axial slices we just talked about. A computer then uses complex math to build the image, which is fantastic for viewing really dense structures. Now contrast that with magnetic resonance imaging, or an MRI. An MRI doesn't use X-rays at all. Instead, it uses incredibly powerful magnets to literally align the randomly oriented hydrogen protons in the water molecules inside your tissues. By sending radio pulses and measuring how those protons return to their aligned state, the computer maps out high-resolution soft tissue. It's wild.
Let's contrast two more really fundamental tools. Traditional X-rays rely on something called radiation attenuation. Because bone attenuates, or basically blocks X-rays the most, bones appear stark white on the film, while air-filled spaces like lungs appear dark. Ultrasound, on the other hand, uses zero electromagnetic radiation. It relies on a piezoelectric material to emit and receive high-frequency sound waves that just bounce off internal organs completely safely. With Doppler ultrasound, clinicians can even capture real-time movement. They can measure the exact velocity and direction of blood flow to instantly spot blockages.
But here's a problem. What if bones and soft tissue are completely blocking your view of a specific blood vessel? Well, enter subtraction angiography. This is just a marvel of modern mapping. Here's how it works. Clinicians take a pre-contrast image and invert it into a negative. Then they inject a safe contrast agent, like an iodine-based dye, into the patient's bloodstream and take a second image. The computer then literally subtracts the negative image from the positive one, entirely erasing the bones and soft tissue from the screen. What remains is this solitary, absolutely flawless map of the contrast-filled blood vessels.
So, from the basic physical coordinates of the anatomical position all the way to the atomic-level alignment of an MRI, the way we chart the human body is nothing short of miraculous. Today, we're even seeing hybrid technology, like PET-CT scanning, which can actually layer a map of the body's metabolic function directly on top of its physical anatomy in a single image. It really leaves us with a fascinating question to ponder. As these hyper-accurate functional maps continue to evolve, how are they going to entirely redefine the way we diagnose and treat the human body tomorrow? Thank you so much for exploring the map with us on this explainer. Keep wondering, keep learning, and I'll catch you on the next one.